Good evening, everybody, and welcome to this evening's Facebook Live. I'm Alec O'Dare. I'm the MD of Wound Care People. Tonight's event is brought to you in association with B. Braun. So first and foremost, as always, I'd really like to thank them for sponsoring this event. And the session title is Wound Bed Preparation, Implementing the Optimum Pathway. We've got two fabulous speakers here this evening. We've got the wonderful Jenni MacDonald, who is a nurse consultant tissue viability, acute, primary and community care over at up at NHS Lothian. And we've also got Anita Kilroy-Findley, who's the clinical lead tissue viability, Leicestershire Partnership NHS Trust. Jenni, Anita, how are you?
Good, thanks.
Yeah, fine.
Are you raring to go? We've for those of you that were at our Wound Care Today event this week, it's been a bit of a hectic week because we've been back at our first major conference, which is very exciting. So I know that Jenni in particular, who was there, got home at sort of middle of the night last night, we all say. And so to be here this evening is, we're very, very pleased. So thank you very much for your effort. Just quickly, Jenni, how did you find the being back at a face-to-face event?
Oh, it was great. I think there was such a buzz, wasn't there, Alec? People were just delighted just to get stuck back in again.
Yeah. Can I give a quick shout out as well to anybody who's watching tonight that stopped me at the conference and said, "You're the guy from Facebook," which happened quite a lot. So I've obviously been doing quite a few of these, and people have started to recognise me, which was a very odd feeling. So as always, certificates for the events will be available at the end via a link. There's going to be some other links from B. Braun that you'll be able to get access to. Slides will be available after the event via our website. The photographs from the slides will need to be removed, but the actual the educational content that's within them will be available. So you'll be able to download those from tomorrow afternoon. As always, please ask as many questions as you possibly can, because we'll be coming back after the presentation for a live Q&A with Jenni and Anita. I think that's about it for me. Just finally, just bear with us if there's any technical issues. You can see that we're as usual presenting from our homes, and we're going to continue doing that until the end of the year, and then we're going to go back to the studio, and it'll be a slightly different setup. So yeah, that'll be exciting as well. Enjoy the event. Anita, Jenni, over to you. I'll see you back for the live Q&A. And as I said, enjoy everybody, and please do ask as many questions as you can.
Thanks very much, Alec. Hi, everyone. Thanks for joining us this evening. I'm delighted to be here. It's been a while since I've done a Facebook Live, and like Alec said, I'm still buzzing from the conference of the last few days. So, wound bed preparation and the optimum pathway. So for this presentation, we really want to explore wound bed preparation with you, but to understand how that fits in the role of wound healing. And we're going to touch on understanding biofilm and slough's role in delayed wound healing. So as we know, wound healing is a complex process, and it is dependent on many interrelated factors. It takes place in a sequence or phases of wound healing, which I'll touch on in a second. Wound healing, it requires the local environment to be absolutely optimal. And that local environment can really easily be disrupted by intrinsic factors and extrinsic factors too. Intrinsic meaning inside the patient, and extrinsic meaning outside the patient. So the phases of wound healing, you've probably seen this before, but a good refresher all the same. So there's 4 phases of wound healing, starting with hemostasis, moving to inflammation, moving to proliferation, or some people call it the granulation stage, and the 4th and final stage is the remodeling or maturation stage. Now these phases overlap, and to move on to the next phase can depend on all those factors that I was talking about. We know in chronic wounds, this timeline is stalled because they're often stuck in phase 2, the inflammation phase. So as clinicians, to achieve healing, it's absolutely essential that we understand these phases of healing. And I can't underestimate that. Because when we're assessing a wound, we really need to be able to look, listen and learn, and really be able to identify the phase that the wound might be stuck in. Like I said, if it's a chronic wound, it's often the inflammatory phase. And the reason we need to know that is because we need to understand and recognize abnormal healing. We need to understand barriers to healing and then intervene early. Now I'm going to talk about wound bed preparation. And when I do that, we have to be mindful that wound bed preparation refers to wounds that are healing by secondary intention. So that's the wounds that are healing from the inside out. So it doesn't include wounds healing by primary intention in terms of sutures and clips and glue, for example. So healing from the inside out. Now I've got a nice picture of a cake here, and that will come clear in a second. But when we're talking about wound bed preparation, it's essentially the clinician, you and I, taking a very proactive approach, taking proactive steps to make sure that that local wound bed is ready and prepared for healing. So wound bed preparation for me is a little bit like a recipe. It's a bit like baking a cake. So if you were baking a cake, you would have to get all your things ready, your butter, your flour, your eggs, and you'd have to do actions. You have to do something with your ingredients. So you have to preheat the cooker, X, Y, and Z. You understand what I'm getting at. So essentially, to prepare the wound bed, the recipe and the optimal pathway is cleanse, debride, and prevent. So normal wound healing, autolysis is the removal of devitalized tissue, and the body does it itself, but very slowly. And like I said before, chronic wounds are stuck in that inflammatory phase. And to you and I, when we're assessing that wound, it looks like increased inflammation. There is that delayed autolysis and there's delayed healing. So what we need to do is we need to intervene and help that wound move on to the next phase of healing. Now, the wound healing continuum, many of you would have heard about this before, and it's one of my favorite things to teach, quite honestly. And the reason for that is it's so simple. In tissue viability, there's lots of big words and words we can't often spell, never mind pronounce. But the wound healing continuum means you don't need to know those fancy diagnostic words. You need to look at the colours of the wound bed. And the wound healing continuum helps the clinician to understand that they need to intervene to move that patient's wound across that colour spectrum to pink. So essentially, if your patient's got black in their wound, yellow, orange, we need to intervene. We need to help push that wound into the red and the pink stage. Like I say, we don't need to talk about fancy words, just let's look at the colours. Slough is one of those words, and we use it quite frequently. And it can vary, it can look very, very different. So sometimes it's kind of a brown, or it could be a yellow, sometimes a bit of an orange colour to it. And it's got different consistencies as well. It can be thick, it can be thin, it can be dry, it can be wet. But essentially, slough is made up of cellular debris, and that is caused by that inflammatory phase that I was talking about. Inside that slough, there's white blood cells, there's bacteria and debris, and essentially it's dead tissue. It becomes a vicious cycle because chronic inflammation can lead to slough, and then slough can lead to chronic inflammation. So like I say, it's a vicious cycle. And the problem with slough is that first of all, it prevents normal wound healing. And what I mean by that is slough in the wound bed is a physical barrier and it stops those wound margins closing. So it's actually a physical barrier to healing. Slough, because of that vicious cycle with inflammation, it can almost mimic an infection. So you might treat that patient for an infection, and it's not infection at all. Slough, if it's there, will increase odour and increase exudate. So we have to think about the quality of life implications of that. Slough increases the risk of infection in the wound. And if slough's there, we can't actually see the bottom of the wound, so we don't get an accurate wound bed assessment either. Slough will nourish bacteria and attract more bacteria and bioburden as well, which we'll touch on shortly. And the other thing is, if there's too much slough in the wound bed, you can't actually get a good wound swab. So there's so many things that slough becomes a barrier for. So this slide is some nice pictures of slough, and it's just to reiterate that it can look very, very different on different wounds and different patients. So the image on the left is that there's a very thin coating of slough. It's quite adhered to the wound bed, and it doesn't look too wet. Whereas the one on the right, you can see, is covering 99% of the wound bed. It looks wet, the viscosity is different. So it varies between patient to patient. So the cycle of slough, again, this is another vicious cycle. Essentially, slough forms on the wound surface, and it will lift ever so slightly and quite slowly, as the body would naturally do. But the problem with slough being in the way is bacteria will colonize in this slough. And what I mean by that is the bacteria will find the slough, they'll realize it's warm, it's cozy, there's loads of food here, we're going to stay. So the bacteria move in, they invite their friends, their family, their second cousin, they order in a pizza, they're looking at a DFS corner sofa, you're not getting rid of them. And what happens is the immune system goes, wait a minute, you weren't invited. And what it tries to do is it tries to flush them out. And what that looks like to you and I is exudate. So the body's natural way is trying to get rid of that bacteria that are moving in their droves is to flush it out. And what happens is the peri-wound gets damaged, you get maceration, and then cellular activity speeds up. Then more slough forms, more bacteria move in, and again, you find yourself in a vicious cycle. So we really need to do something about that as clinicians. So I'm not going to go into too much detail here around the cycle of biofilm, but essentially, as I said, the bacteria will move in, they contaminate the area, they start replicating, they colonize, and then the inflammatory response kicks in. Anita, who is coming on shortly, will go into a little bit more detail around biofilm. Essentially, biofilm, you can find it anywhere. It can be in the wound bed, it can be in slough itself, in necrotic tissue, in the wound exudate, on the dressings. And essentially, slough and biofilm are very, very difficult to get rid of. So what do? We implement the optimum pathway. And the first step to make our cake, remember our recipe, the first step is to cleanse the wound. And we cleanse the wound for lots of different reasons. Quite obviously, to you and I, to remove some slough and debris. But cleansing also helps to reduce the bioburden and the biofilm in the wound. It might remove some slough so we can get a better wound assessment. It cleanses up that exudate. And again, if we're going to take a wound swab, we need to clean that area so we can get the best wound swab possible. And this is just a before and after slide to show that actually maybe we underestimate cleansing. So the before is on the left, and then on the right, you can see that cleansing's actually made a good improvement here. The second step to the optimum pathway is debride. So the process, debridement is essentially the process of removing necrotic and devitalized tissue. It removes bacteria and cells that are impeding the healing process, and it helps to reduce wound contamination and tissue destruction. Essentially, what we're doing is loosening and removing that slough from the wound bed the wound edges and the surrounding skin as well. So what happens if we don't debride? What happens if we miss that second step? Well, if we don't debride, we are going to get delayed healing for that patient. We are going to get increased wound infection. And these two things are going to have a really negative impact on the patient's quality of life and well-being. And if we're not even giving the patient's wound half a chance to get on that healing spectrum, there will be an increase in nursing visits or appointments, an increase in nursing time, and a cost to the NHS as well. So we can't skip any of the steps. A lot of time we get questions around debridement, and there's lots of different ways to do it. And on the right-hand side here, there's a table of the most common methods of debridement, and I've listed them in order of speed. So at the bottom, your autolytic debridement, that's your hydrogels and your dressings to soften that slough, and it will eventually come away. So there's biosurgical, which is our larvae or maggots. Mechanical, which I'll talk about in a second. Sharp debridement, obviously, you use a scalpel, and you do need to be fully trained before you can do that. And the surgical option is actually by a surgeon in a theatre. But the mechanical debridement is what I really want to focus on in this presentation. So many of you will do it already, or have you seen about it or heard about it. But essentially, it's a mechanical debridement, and you don't need to be a specialist to use this. Essentially, it's a debridement pad that you mechanically, by friction, remove that slough from the wound bed. And Anita will talk a bit more about that. But the main point I'm trying to say is you don't need to be a specialist or do a special university module to do mechanical debridement. So the third step in the optimal pathway is prevention. So if we're cleansing the wound, we're disrupting by mechanical debridement, the biofilm and the bacteria, they will come back. As soon as you look away, they're coming in that back door, and they'll be back within 48 hours. And we know that antibiotics are not going to work for biofilms. So that's why we need to be very proactive in implementing this 3 steps. Between dressing changes, if maybe you don't see a patient for 48, 72 hours, maybe it's a dressing change once a week, that biofilm will be back. So we need to implement the 3rd step of the pathway to make sure when we're not looking that bacteria has been kept under control. So the optimal pathway: cleanse, debride, prevent. If you don't remember anything from the presentation tonight, please remember the 3 steps. And the first step, just to recap, cleansing will loosen slough and the superficial devitalized tissue. Debriding is that force to start breaking up that bacteria when they've moved in and they've got their takeaway. You're disrupting their home, so they don't want to live in them anymore. You're evicting them. And then prevent. When you're not looking, you know they're going to come back, and they can grow really quickly. So we need to add a biofilm suppressant in there before the next dressing change. I've got a couple of pictures just to show you before and after wound bed preparation. Now, this is a typical wound that we would see. You can see that there is some slough in the wound bed. You can see some varicose eczema, some hyperkeratosis. And actually, after your cleansing and mechanical debridement, wow, like what a difference straight away. You can see the difference of implementing this pathway. There's a picture of a wound on the foot there. Again, using that debridement pad, it might take a couple of goes, but not always. You can see how quickly you can take that home away from the bacteria. You're really giving your patient a foot up in the wound healing continuum. And you can see the colours. If you think back to the colours that I was talking about, so the yellow on the left-hand side, just by implementing cleanse and debride, you've pushed that wound across that wound healing continuum into this red space, and that's where you're going to get healing. If I haven't said it enough, the 3-stage process for the optimal pathway is cleanse, debride, and prevent. So how do you know it's worked? We get this question all the time. And when we're doing wound bed, we're doing a wound assessment, we use the TIMES framework, or depending on where you're practicing, a slight iteration on that, but generally the TIMES framework. So if you've implemented your wound bed preparation with your 3 steps, you'll be able to do your wound assessment using a framework, and you should have clues coming through that it's either working or it's not. So to break that framework down, T for tissue type. Like I said, if your wound bed preparation is working, you'll see the colours changing from that brown, black, yellow through to your reds and pinks. You know it's working. I for inflammation and infection. If your wound bed preparation's working, your inflammation should reduce, and your patient shouldn't be getting infections. M for moisture. If your wound bed preparation is working, you should see the exudate levels drop. And E for edges, you should see the edges becoming pink and healthy rather than saturated and white and macerated. Again, for the surrounding skin, if the peri wound was problematic before, you should be seeing that improve. So using the TIMES framework, you can go through each letter of the acronym and ask yourself, am I seeing a difference here? Am I going the right way? Is my wound bed preparation working? And you can take a bit of a step back and actually ask yourself, is my healing rates improving? Are the measurements of this wound decreasing? Looking across your caseload, for example, is the infection rates after implementing this pathway, are they reducing? And a key thing when you're looking at a caseload in the community, for example, or in a clinic setting, you can tell if what you're doing is working, because actually your patient's dressing change frequency will reduce. They don't need to see the clinician as often. That's a really good indicator that what you're doing is working. Now I will hand over to Anita. Thank you very much.
Hi everyone, thank you Jenny for an excellent presentation, and thank you to the Journal of Community Nursing and B. Braun for inviting me to speak about something that actually is one of my favourite subjects, let's be frank here. So moving swiftly on, I'm going to start with what's the problem? Well, it was bad enough before the pandemic, let's face it, but we've got nurse shortages out there, and we've got increasing patient complexity, and that's got a huge effect and a huge impact on our workforce's ability to respond to patient need. We've got wound prevalence has gone up by 71% in the last 5 years. That's massive. But nurse recruitment has seen significant changes. So there was a cut in funding 11 years ago. Saw the abolition of the diploma course and the bursary that narrowed the recruitment pool. And I know we have learning grants now, but that's not filled the gap yet. It's partially addressed through NAs coming through and the plan for apprenticeship. But again, this isn't going to impact for years. So increased patient numbers versus reduced nurse availability equals task orientation. Why is that important? Because it's the biofilms friend. Swabs requested with an evidence base. Oh, this does my head in. Let's be perfectly frank here. What is it about swabs? We request them. It's not healing. It must be infected. Yeah, okay. But biofilms won't be picked up as a problem in the wound because the bacteria are there in low levels. You think, how many swabs have you done on some of these wounds that have come back that say no significant growth? And you think, oh. So problems with staff doing swabs. Yep, we have those too. And as Jenny said, you must clean the wound first. So many people don't. Or they have these really big wounds and they only do one swab and they think, oh, right, that looks the nasty bit just there. No, wrong. You know, the research on swabbing is quite poor, to be honest. Most people, we look at the Levine technique. But again, you need to warn your patient, this could hurt a bit, because you're actually going to press in to aspirate a bit of fluid from the tissue. Why do that? Well, if you don't aspirate the tissue, how are you picking up the anaerobic bacteria that could be causing you a problem? So let's make sure we do our swabs correctly. If it's a big wound, we do more than one swab, divide it up, and think about the cost of wastage from swabs that aren't needed, swabs not taken correctly. So other things that we have a problem with our wounds, dare I say it, flucloxacillin, 500 milligrams QDS repeatedly prescribed with no effect, because that seems to be the first line, isn't it? First line antibiotic for a skin infection, fluclox, 500 QDS, excellent, has no effect. Why is that? Because biofilm microbes can resist high concentrations of antibiotics. They can actually do that up to believe that you're not 1,000 times more than their planktonic equivalent bacterial. And you've seen yourself how topical antimicrobials, especially silver, are misused. And mismanagement can lead to months or even years for your patient with a painful, smelly wound. Mental health suffers, family relationships are strained, and actually, because of all the antibiotics and analgesia we're pumping down them, their kidney function's affected, ka-ching. Oh, and social interactions reduced. I think that's the problems summarised. So if we think about what we see out there, the wounds we have here, the top left one, you can see there that that is clearly an inflamed wound. We've got slough all over it. We have, that will have had numerous negative swabs, a lot of exudate on it. We also have the wound picture at the bottom left, where we've got non-healing, poor quality granulation. You can see that from the pale pink. Top right, lots of people will see that and say, oh, it's got a biofilm. It's got easily removed gelatinous material that, because of the chronicity of the wound, there's likely to be a biofilm, but don't just tick that box on the gelatinous material alone. We have the rapidly reforming slough, and you can see with the middle picture, it's all debrided out nicely. And then all of a sudden, if you look at the picture bottom right, a couple of days later, oh, the swab's reformed. So think about it. If you had these wounds, would you think they're infected? Would you swab them? Would you get them antibiotics? Think about the visuals that you're looking at. Think about what you were trying to achieve, what might be causing you a problem. Don't revert to type of repeat antimicrobials, repeat swabs, repeat antibiotics, because that is not addressing your root problem of the biofilm that is causing you the problem. So what do we know? Well, early research suggested that 60% of wounds might have a biofilm, but that figure's increased now, and there's been a number of studies. And for some wounds like diabetic foot ulcers and venous leg ulcers, there was a study in 2014 that identified 100% of them had a biofilm. And the biofilm microbes differ. So they're not planktonic, so they're not the free-floating bacteria of the isolate infections that you might see, but they adhere to surfaces and they can stick like glue to them. And they stick to other microbes as well. And as they mature, they get encased in this lovely, lovely extracellular polymeric substance, otherwise known as EPS, and they create their own micro community. So with the picture here, the green that you see is the EPS, that's the protective layer. And it contains everything the bacteria and fungi need. So it's got the sugars, it's got proteins, it's got glycolipids, it's got DNA. And in fact, these little suckers are so intelligent, they build their own little water-cooled towers. It's the it's the biofilm equivalent of an all-inclusive hotel. Ka-ching, they're in heaven. And they talk to each other. And they do this. You might have heard the term quorum sensing. That's the term used to describe the levels of communication that they have. Whereas before an infection may isolate one active bacteria causing the symptoms, these babies fly under your radar because they're metabolically dormant. And that's why your antibiotics don't work, because antibiotics rely on disrupting the bacterial metabolic process. Well, if that's dormant, then they're not got anything to act on. There's your problem with your fluclox QDS. And the EPS is your protective house for the microorganisms. So think about 70s clear plastic umbrellas, nothing gets through. Well, that's what the EPS does. And it defends the bacteria against threats that might normally kill them. And because of their quorum sensing, then they share some of their genetic sequencing. So if bacteria X is resistant to ciprofloxacin, flucloxacin, and erythromycin, then it is going to share that genetic sequence with its mates, and they're all going to be resistant as well. Nightmare. So Evidence shows us that your biofilms exist not only on wound surfaces, but as Jenny said, within your slough and necrosis, and in slough and in exudate. And not only that, but even once you've removed them, then they'll reform again in 24 to 48 hours. And if that's not bad enough, they like to share with the adjacent wounds, and they will jump to adjacent tissue. And you will see satellite areas opening up that have a biofilm too. So the only way to identify your biofilm really is biopsy or deep aspiration, because we have multiple species of bacteria. But there are a number of ways that you can check that actually my wound has things going on with it that mean I think a biofilm is present. So, as Jenny said, we need to put in a strategy to address our biofilm through the cleanse, debride, prevent mechanism of your wound bed preparation. And here you can see we've got saline or water has no active ingredients in it. So yes, you can cleanse a wound in it, but you know, it's not going to do anything active to your slough and biofilm. It may remove a little bit of loose debris, but if you've got anything sticking, then it's just passing straight over it. There was actually a document some of you may have seen by Wounds International in 2019 called Surfactants and Their Role in Biofilm Management. If you've not read it, it's worth a read. You can download it. And that was saying that if you leave your surfactant in situ, then it will disrupt the extra polymeric substance on your older biofilms. So think, leave my Prontosan in place, it is going to cleanse them, and it is going to disrupt the biofilm that is there. Combine that with your surface scrub, your mechanical debridement, and you're going to help your microbes not attach. So there's things there that tie in quite clearly with Jenny's message on what we need to do. So in Leicester, I've always loved biofilms since I first came to my notice. And in 2017, we devised our own pathway on looking at the evidence and how we could improve patient experience and healing rates by developing a step-by-step pathway that people could follow. And I think the important thing with this is it's important for people to understand that wounds can go backwards as well as forwards, and it needs to have a flexible approach, and the pathway allows for that. So this is a sample part of the pathway. And you can see that we actually have gone down tissue types just here, and the rest of the pathway did have the same bits. And it goes across in stages, as you can see. So we start off with what the aim will be, how long we want to soak, use our debridement pad, and then use our Gel-X and an absorbent secondary dressing. We have actually recently, we're looking at updating our pathway, and as part of that, we've reviewed debridement pads. We now use the Prontosan debridement pad because we found it more effective than the alternative that we were using. Patients reported they found it less painful. Clinicians found it more effective on hyperkeratosis, and even better because if your patient had emollients stuffed on their legs, it worked even with those present too. Plus it was easy to handle, and actually it's more cost effective, so the CCGs like it. It's available in packs of 3 or 10, which is another double whammy. So the Leicester pathway is easy to use. We adjust our soak times according to what the wound bed looks like, and the pathway spells that out. Some patients have shared care, and one of mine, I only saw them every 5 weeks. They looked after it themselves in between. We found that DAC dressings are a good medium for the gel retention and helped with exudate management. And when Gel-X came onto the market, we quickly moved across to that because we found it was more viscous and a thin layer put onto the wound. And can I say a thin layer, not a big blob that when you go like that with your secondary dressing, the Gel-X goes, poof, yeah, waste. Thin layer, and that is going to get into the wound and help prevent your biofilm reforming until you've got your next dressing change. So this was one of our patients that we tried it on. And he was 72 years old, as it says, and he'd had it over his leg ulcers for over 4 years, and it had a massive impact on him. And yet there was no reason he shouldn't have healed, except we didn't understand biofilms. So this was back early 2017. It meant he'd received multiple courses of antibiotics, swabs, and silver dressings, all those things that we mentioned earlier. But you can see that over a short period of time, his wound actually progressed nicely. And that was from using the process of cleanse, debride, prevent. So this next slide is the same gentleman, and just another part of his leg. And the first photo to the far left was taken when I first met him on the 18th of September. We implemented the pathway, and the middle photo was taken on the 3rd of November. And you can see how massively this wound has started moving towards healing. But even more phenomenal is that within a couple of weeks, on the 23rd of November, the picture on the far right was taken. And that was just great. But it can also be used on those hard to heal wounds. So this wound here is one that we became involved with. He'd had for years. He was 62, insulin dependent, clotting disorder, multiple DVTs over 40 years. His legs were so indurated, they were absolutely solid. We needed to personalise our biofilm management strategies to this gentleman to make sure the product matched the wound's needs. And he utilised the soak and debridement pad, but used an alternative antimicrobial dressing, and that was absolutely fine. And you can see again the progression of his wounds. So the photo on the far left is when I first met him. And then a few weeks later, we've got one taken on the 28th of February, 5 weeks later, I should say. And you can see significant improvement and healing. And then literally a month later, we've almost got it to healing. This guy had had these for years. So it can have a massive, massive effect. So what do? We know that we have to manage the biofilm. Debridement is key. Whether you do sharp, mechanical, with a debridement pad, whatever you do, it is absolutely key. We have to remove the EPS. We have to stop these microbes from attaching to the surface. These are the same microbes, by the way, that causes the problem by increasing inflammation at the site through an overproduction of proteases. Without removing our EPS, we can't get to those microbes. Why do we need to soak? Well, to be fair, it does what it says on the tin. It breaks down the EPS, it disturbs the microbes. And this is a really important part of your biofilm management. Remember, saline and water will not do this. They have no active ingredients. We actually use the Frontosan solution on our debridement pads as well. Really gets into the wound edges because you've got to scrub those edges. Biofilms love wound edges, okay? So make sure you get right into those. And please note, cleanse your wound. Do not put the leg in a bucket of Frontosan. And you might think that's really stupid, Anita. And of course it is, but trust me, I saw it. Leg washing is important for well-being and hygiene and hyperkeratosis removal, but a soak is literally a soak onto the wound to start your active treatment of wound bed prep and biofilm wound management. We had great patient feedback. It improved their quality of life. They had ownership. We educated them. The pilot was built on, wasn't suitable for everyone, and we did learn. So the new debridement pad, using Emla cream on those really neuropathic pain ulcers, also giving the patient the debridement pad so that they could do it themselves because they could manage their pain, showing them pictures to help them understand. All of these things improved concordance. So why aren't we proactive? Well, we know at the moment it's really tough out there, really tough. Community is really struggling. But is it a lack of knowledge? Is it frustration with the semi-concordant patient? Is it not being able to see the wood for the trees? The wound hygiene consensus document from 2019 is absolutely clear on the proactive management of biofilms. We need to clean the area. We need to debride the microbes, the slough-laden microbes. We've got to clear those crusty edges. And actually, the document recommends we do that with our little debridement pad to pinpoint bleeding. Warn your patient first, else they might think you've been tad aggressive. But we've got to implement strategies that are going to stop it regrowing. And the Frontosan range of irrigation solution, debridement pad, and Gel-X meets all those requirements. And if that's not enough to convince you, just take a look at this one. This is a 3-year-old ulcer, and you can see the picture on your left was taken, and it took us 6 months to heal that ulcer for that patient, okay? The picture on the right is that leg almost healed, but we had 2 months worth of cost savings. So your total cost before the pathway was £3,279. That is one hell of a lot of money. Total cost of 2 months on the pathway is £1,151. So you offer your CCGs a saving of £2,128, and I can guarantee they will bite your head off. Hand, did I say head? Oh God, sorry. Anyway, if you'd like a copy of the pathway, talk to your B. Braun rep. They're a great support, I found, and they will be able to give you copies. Thank you very much.
I think we're back to me, Anita. Sorry, I was waiting for you to say something and I was still muted, so I do apologise. I love your enthusiasm. You are it's just I've never seen anything like it. We've got loads of questions. How did you? Are you both okay? How did you find that? Slightly jaded after a long day and another presentation.
No, it's a great topic, Alec. If we just implemented it across the board, our outcomes would be far, far better.
Yeah, no, I can see that. I think the enthusiasm from the two of you really comes through, actually. So thank you for tonight. Let me get over to the questions. The first question is from Rebecca, and this is for you, Anita. This is, if I miss a visit or a debridement, does it matter?
Yes. I'm afraid it does. And I think this is one of the things, the challenges to getting nurses to understand this, that actually, if you look at the rapidity with which a biofilm reforms, so that 24 to 48 hours, if you miss a visit and you don't tackle it, it's already fully reformed and you're back at the start. So whilst you're getting that biofilm management kick-started and you're progressing the wound along to more of what I would call the maintenance stage, or what we had as stage 2 of our pathway, where we were using a Prontosan soak and the Gel X, and we no longer needed the debridement pad, you are still, you still need to use your pad. You've still got to get it debrided until you're at that stage. So sorry, yes, it does.
I think that's a fairly comprehensive, definite yes, it does. So there you go. Hope that answers your question, Rebecca. Question number 2, this is from Anna for Jenny. What's better, sharp debridement or debridement with a pad?
It depends what your plan is, Alec. Sharp debridement is always, the faster, quicker option, absolutely, if it's not contraindicated. But like I said in my presentation, you need to go to a training course to do that. So if you don't have a sharp debrider in terms of a tissue viability nurse, a podiatrist, then mechanical debridement is a great intervention as well. Yes, it's not as fast as sharp, but like I say, anyone can do it. So some debridement is better than no debridement.
Yeah, okay. Question number 3, this is from Mel. This isn't to anyone in particular, so it's just a question. So I'll ask it and then maybe you can say who wants to answer it first. So it's, do you have any additional advice for managing wound beds for palliative patients where healing isn't necessarily the main goal, rather a huge area, I know? I'll let you both have a think about that. Who wants to go first?
I actually, if you don't mind, Jenny, because this comes up, and it's something I actually feel quite passionately about, and maybe it's because I'm a mental health nurse, but we are very much, it's what the patient wants. What's the patient's goal with these wounds? If their goal is, oh well, I want it to heal, then there is a frank and perhaps difficult conversation that needs to take place, and the setting of some real goals, which could literally be fewer dressing changes, something that will absorb the exudate more, something that will reduce the smell. But I really do feel very strongly that it isn't about what we think, it's about what the patient thinks, what the patient wants. But if what they want is not achievable, then we need to provide context for them. And more importantly, choices within that context, so that they're not just faced with, sorry, this is all we can do. There needs to be choices and pros and cons given so that they can make an informed decision.
Yeah. If I can just follow up on that, absolutely, Anita, we have a similar conversation, and we call it what matters to you. So we ask the patient quite openly, what matters to you about this wound? And like you say, it could be, if the patient's at end of life and they have accepted that, and healing is not the goal, the patient will say, can you just stop the odour, or can you help me with the pain, or it's leaking all of my bed. If it just didn't leak, my life would be better. So having that asking that question, what matters to you? There's your treatment plan. It's there for you. I hope that's a.
Yeah, I think so. Hopefully, Mel, that answers your question. It's a really tough one, isn't it? I guess so. I don't envy the position that all of you nurses must find yourselves in at times when having to deal with these really tough things. The next question is for Anita. This is question number 4. This is it always necessary to soak with a cleansing solution? So they're obviously talking about the product there.
So yes, if you're looking at good wound bed prep and potential biofilm management, then the use of a soak, and your soak can be timed. We have some wounds that appear to be clean and granular, but we'll have a biofilm that we can't see, that actually a 5-minute soak, Bob's your uncle. But then you'll have other wounds where that slough that Jenny was describing so well is stuck to the wound bed, and you need to loosen that off a bit, and you need to really get into it to start breaking down your biofilm. For those wounds, you're going to be looking at more like 10 to 15 minutes. So yes, the soak is essential, but you can tailor it according to what your wound bed actually looks like.
Okay, thank you. Jenny, this is from Rachel. I think you touched it. I think Anita, you touched on this, but the question is for you, Jenny. This is, can patients debride themselves?
Anita did touch on it, absolutely, yeah. And it's something I advocate. There is a big shift towards self-care, but I remember helping patients. I was actually in a mental health hospital, Anita. I remember when debridement pads first came out in the market, and again, the only contraindication from a debridement pad really is patient tolerance. And patients actually tolerate a better debridement with a pad if they do it themselves. So absolutely. So I have, quite frequently said to patients, now, this is the 5 steps to wash your hands. What glove size are you? Give them their gloves. Tell them how to moisten the debridement pad. I always kind of describe it as tea towel damp, and show them to use it in a circular motion. Absolutely. The answer is yes. But as long as you have the education alongside, they need to clean their hands, they need to moisten it. So they use the product properly, but also understand why they're using it. And you can use really simple terms that you're scrubbing the bacteria or something. As long as patients understand why they're doing it, you'll probably find that they give a better debridement than you, because they can feel the pain.
Yeah. Do you want to, as soon as it was you that mentioned it, Anita, do you want to add anything to that?
My favourite is my guy. He used to just do it in the shower. He'd have his and he was the guy with the who I showed as one of the case studies with the clotting disorder, and to be honest, I swear he scrubbed it harder than I would. Yeah. I am a big advocate of shared care and self-care. Absolutely.
Brilliant. Okay, so the next question, somebody is saying that we use tap water. What's the benefit of using an active cleanser? Anita, do you want to tackle that one?
Well, tap water, other than removing some surface debris, like if you've got a bit of liquefying slough, for example, or maybe you've got a bit of dressing debris on it, your tap water will do that absolutely fine. But from an active point of wound bed prep, loosening your slough or necrosis, and starting to tackle a biofilm, tap water's got no active ingredients, whereas the cleansing solutions have a surfactant in them that will start attacking your microbes. So that is why tap water, I'm afraid, is nowhere near as good as some of the commercially available cleansers.
Okay, I think that's pretty clear. This next question is from Charlotte. This is, hello, I'm a third-year nursing student doing my dissertation on the assessment and management of chronic venous leg ulcers. Apart from holistic care assessment, is a key factor of the nurses what role, how can early, somebody's typed this, right? Not you, Charlotte, by the way. This is that I don't see your question. Somebody copies it and sends it to me. I'm trying to figure out, I'll just read it as it is. You tell me whether I'm just misunderstanding this. Hello, I'm a third-year nursing student doing my dissertation on the assessment and management of chronic venous leg ulcers. Apart from holistic care assessment, is a key factor of the nurses what role, how can early implementation by using the optimum pathway cleanse, debride, prevent, help with healing? It's that bit in the middle, isn't it?
Yeah.
It's trying to figure out what the question is. Can somebody just, it's question number 7, somebody in my team, can somebody from my editorial team that's copied that over, can they just reword that question? I'm going to move on to the next one. We'll come back to that, Charlotte. So I do apologize. I think we may end up getting slightly confused. This next question is from Kirsty. This is, what do you recommend for overgranulation? Jenny, do you want to take that just because Anita took the last one?
So for overgranulation, you're always trying to find the root cause. Absolutely the root cause. Sometimes overgranulation, it's going to happen because of 2 things. 1, because there's a foreign body, or 2, because there's a bioburden in the wound. The foreign body, I mean, is something like a peg tube is a good example. It shouldn't be there and the body tries to reject it. And that happens, you know, you get overgranulation from that. So a foreign body that's pulling or shearing or there's friction. So identify the root cause is the first thing. So if there's not a foreign body, there is too much bacteria. And it might not be an active infection that causes exactly what Anita says. It doesn't need to be a full-blown infection. It can be that low biofilm that are ticking away, and you get that hypergranulation. And that's the body's kind of overreaction to what's going on at those bacteria kind of ticking away. So finding the root cause. If you don't understand the root cause, you're not going to treat it well. If the root cause is that foreign body, peg tube's always a good example, then it might not be the right size, it might not be the right material it's made from, so it might not be secured correctly. So if you get the root cause, you'll be able to make some improvement. If it's caused by bacteria, then we're obviously going to want to manage that bioburden in the wound with antimicrobials. But the main thing is, Alec, is to really find that root cause.
Okay. We've got the question back from Charlotte. So third year nursing student doing a dissertation in assessment and management of chronic venous leg ulcers. Apart from holistic care assessment, how can early implementation by using the optimum pathway help with healing?
Better, well done. I feel like I know Charlotte quite well now.
Yeah.
The first thing that comes to mind, absolutely the holistic assessment. We can't get away from that. We have to do it to understand our patient and to get the treatment plan right, essentially. But early intervention is absolutely key as well. And I think even at the Wound Care Today conference, Alec, there was a lot of wounds and a lot of case studies. You know, it was on, you know, patients have been having wounds open 6 months, 2 years, 5 years. And it's about that kind of implementing early. And if your implementation doesn't work, then escalating to a specialist early as well. Biofilms, like Anita said, you know, can happen within 48 hours in a chronic wound. And the definition of a chronic wound is open to interpretation. But if you're not getting any healing within a couple of weeks, you can probably guess that there's a bioburden going on there. So yeah, as soon as you're getting that static wound, not showing any signs of healing, probably got a bioburden. So that's when your early intervention should start. Anita, have I covered that? Do you want to add anything to that?
No, the only thing I was just thinking of, because Charlotte was saying that, I think she said she was doing her dissertation on venous leg ulcers, was thinking about the changes that have happened in the last number of years, mainly from the work that Leanne and Joy have done, and looking at how best practices moved from, you know what, if after 2 weeks you've got a lower limb wound that isn't healing, then let's get them into compression.
Yeah.
When I started, it was 6 weeks. With what we know now, early intervention, we can stop those wounds becoming chronic by addressing some of those underlying causes early. And I think that, for me, is one of the biggest messages for early intervention where venous leg ulcers are concerned.
I think we become detectives, don't we, Anita, as TVNs? You know, everything is about the root cause, underlying disease, you know, and we're there with our magnifying glass. It's all about the root cause.
Well, hopefully, Charlotte, that answers your question. I'm sure that Jenny and Anita would answer any questions you've got. I'm not going to give your email addresses over here, but if you want to send us anything, we can certainly pass it on to the two of them for some direct responses for you. Question number 10 is, how long would you use the biofilm pathway for? Jenny, do you want to take that?
Well, Anita kind of touched on it as well. Yes, you've got 3 steps, and it's absolutely key to follow all 3 steps. And some people do think you need to stop the debridement phase when the slough is gone, but the biofilm's still there. So, you know, with any pathway or any antimicrobial, generally I would use it for 2 weeks. And if you're getting a good response, carry on. That's the general kind of rule. If the wound isn't responding, then there's something else going on. I don't know about you, Anita. Is there a fixed in your pathway that you developed? Is there a fixed time frame?
Ours is a 2-week review.
Yeah.
You know, and if you know what we have found with experience is that we haven't really found any patients who progress unless you use that debridement pad stage for at least 4 weeks. I think if people go back, you know, stop using it too early,
yeah,
and the wound just goes straight back. And I think the other thing is, if people do stop using it and the wound deteriorates, they shouldn't think that their pathway has failed. They need to sort of understand, well, why might it have gone back? It could be something to do with the patient themselves. It's like going back to what you said, you're Inspector Clouseau, you know, what's happened with the patient, what's happened with the wound that might have interfered with that. Okay, well, let's go back to using our debridement pad because we know it improved with that. And some patients as well don't want to stop using the debridement pad because they've got faith in it.
Yeah. But the other thing is, if you 2-week pathway, if we're using it for 2 weeks and evaluating it, and it's not working, we have to be asking, are we implementing it properly each step, every visit? Because that is key as well, isn't it? You know, the nurse that saw the patient on Monday, for example, did step 1 and step 3, and the nurse on Wednesday did step 1 and 2, but then forgot 3. So it's about continuity and making sure that everyone that's caring for that patient is implementing it properly and continuously as well.
Okay, thank you very much. There's a question here that that's from Alex, and this is: if the gel is used to keep the biofilm at bay, would you then use dressings as normal on top of it? Anita, for you,
I'm wondering what dressings they're thinking of. I mean,
well, yeah.
I would not ever recommend mixing product licenses and creating your own new product license. Obviously, there are some products out there that are licensed to be mixed, so hence we use a DAC technology product mixed with our Gel X. But I wouldn't want to be making up any weird and wonderful concoctions. So I think if you were looking at mixing and matching, so to speak to the company reps first, find out whether you can actually do that or whether it would be against the product license.
The other thing to think about, Anita, sorry, Alec, well, we'll give you a word in at some point.
Yeah, it's all right. I enjoy listening to the two of you, and I've spoken quite enough over the last 3 days, if I'm honest, so it's fine. Go for it.
The other thing to think about, Anita, in terms of the effectiveness of the gel is actually, if you want the gel to work, and, you know, I totally get your point about not putting a massive splodge on there, it is a thin layer. But if you go and put a super absorbent on top of that, for example, it will absorb the gel. And do you know, you want the gel to be sitting on that wound bed as long as possible. So yeah, you need to be thinking about how different properties of dressings are going to potentially take your gel away also.
That's actually all I was. That's all I was going to say. I was wondering whether the question is aimed rather than sort of specific dressings, looking at dressing types. Like, for example, whether you'd put a foam over the top of it or whether you'd put a super absorbent. And then, Jenny, you made the point that I was thinking, if you stuck a super absorbent on it, you'd probably suck it up.
Yeah.
But if depending on the wound type, you'd think, you know, things like films and things like that. I guess that's how I see the question anyway. Is it, you know, would you put a film over it versus a foam versus a you know, a super absorber or, you know, something else. So did you want to add anything to that? I think that's probably
no, I think I
covered it. Yeah.
I think I never got over once seeing a wound that had a silver hydrofiber in it, a cadexma iodine paste in it, and oh God, what was the other? It had a gel. Yeah, and it had a gel as well. And I have a photo of that, and I don't think I ever got over seeing that.
That's what you call a dressing sandwich, right?
Yeah. I've heard lots of those stories as well. I think we've probably come up to the last question. So for me, I think if we we'll leave it there. There's lots more questions that I can see that are coming through that we're not going to get time to go through. But as always, what we'll do is we'll collate those questions and we'll share them with Jenni, Anita, and B. Braun. We'll then put a PDF with the answers to those questions alongside the slides, which should be available over the next couple of days via our website. You can watch this back at any time via the Facebook page. You can please do share it with your colleagues if you found it interesting. If you want to watch it again yourself or you want to share it with someone, it's just the link will be available. The recording immediately becomes available for you to watch again from the start after the event. Huge thank you again to B. Braun. It's been a really interesting topic with two really passionate speakers this evening. So I've really I've enjoyed myself. Thank you. And thank you for everybody that's given up their time this evening. As always, we really appreciate the fact that, you know, this is your own time. It's in an evening. It's sort of peak evening when there's lots of other things going on. So we genuinely do appreciate it. There should be some links on the screen now for you to be able to download your certificate and some information from B. Braun. There's an email address that we're putting up there if you've got any questions about anything that you've heard from a product point of view this evening. You can contact B. Braun directly. They'll put you in touch with somebody local to you to follow up on that conversation. So all that leaves me to do is to thank my team as always. Anita, Jenni, thank you both for giving up your time, and thank you very much for a really enjoyable and interesting presentation. I look forward to seeing you on the next one, and good night, everybody.